Let us discuss pulmonary function test. It is very much volatile topic, so you have to revise it many times, and also we have to keep some silly mnemonics. Let us see them one by one. So there are in total 6 subheadings. First, function test, right? So static and dynamic function tests. 2 are done. For a normal respiration to occur, you have to inspire the air, and for that you have to have a good muscle strength. So you will be seeing the respiratory muscle strength. Now the air has got inside, right? So diffusion should occur through the alveolar capillary membrane. So you'll be seeing diffusion capacity of the lung. Now you have to have good cardiac reserve also along with pulmonary reserve, right? So you'll be seeing cardiopulmonary exercise testing. And the final one is metabolic measurement. Let us see one by one. First, static function test, which is whole body plethysmography. In this, what happens is patient is made to go into a chamber, and now he breathes through a flow meter. This works on Boyle's law. Okay? Due to this respiration, there would be thoracic movements, right? So there will be volume and pressure changes also, which would be reflected in volume pressure swings. And these swings would be measured and evaluated and will give you the values. Okay, this is whole body plethysmography. The advantages are it gives us the volume present in bulle also, and also it is a better and easier way to perform. Okay. The second one is spirometer, which is dynamic function test. Okay. Here we'll give a mouthpiece, the spirometer, to the patient. And nose is clipped so that there is no loss of air during exhalation. Okay. Then we'll perform a maneuver called forced vital capacity maneuver. That means now the patient first starting will explain the patient. He has to accustom to the procedure, right? So he'll be taking normal breaths first. Now he has to take a deep inhalation and exhale that as hard, as fast, and as long as possible. That is why it is called forced, right? So he has to exhale as hard, as long, and as fast as possible, which is then followed by deep inhalation. That means the second one. So we'll repeat this almost 3 times and we can get some values. Now, we'll give a bronchodilator and see whether there is any improvement or not. Okay. So as there is a forced vital capacity maneuver, you'll be having a slow vital capacity maneuver. In this, there's also maximum inspiration and maximum expiration. But the inspiration would be slow, continuous, and the expiration would also be slow. But the maximum remains the same. Okay. So in normal individuals, the FVC, forced vital capacity, and the slow vital capacity would be almost equal. But in obstructive diseases, what happens? During the forced expiration, there would be dynamic lung collapse. So the forced vital capacity value would be decreased when compared to the slow vital capacity. So that is the difference. So you have to perform the maneuver and you have to calculate certain things, right? So the first one is forced vital capacity. That means the volume of air that is forcefully expired after deep inspiration, right? So generally normal individuals, almost majority of the FVC would be exhaled out in less than 3 seconds. But this is prolonged in obstructive diseases. Okay. So the value wise, it is decreased in obstructive, restrictive, and lung collapse. Okay. The normal values would be 80 to 120%, and the severe reduction of FVC means it is less than 50%. Okay. So now I'll calculate the amount of air exhaled in the first second. Later, I'll calculate the amount of air exhaled out in the mid half of the maneuver, that is at 25 to 75%. That is the second thing. That is forced expiratory flow at 25 to 75%. And the third thing is you'll be calculating what is the maximum flow rate during the whole procedure. That means it is your peak expiratory flow rate. And finally, you will calculate maximum voluntary ventilation. That means ventilation will be calculated for 1 minute, right? So the amount of air that the patient can breathe in and out, voluntary, right? So he'll be breathing in and out in 1 minute. That is the maximum amount of air the patient can breathe in 1 minute. Okay. So we'll see. For the second one, forced expiratory volume in 1 second. It represents about large and medium sized airways. Okay. Why? Forced expiratory flow at 25 to 75% represents small airways. Okay. First you have done the FEC maneuver. You have calculated FEC. Now you are seeing in first second, which is FEV1, which represents large and medium. The remaining one are small. For that, you'll be seeing forced expiratory flow at 25 to 75%. Okay. So the normal would be greater than 60%. If it is less than 10%, it is severe obstruction. The fourth one, peak expiratory flow rate. That means the maximum flow rate, the total maneuver. Okay. So it is sensitive for obstructive lung disease, and the normal value would be 4 to 5 liters per second. And it also says about the effectiveness of the treatment. Okay. And there would be diurnal variation of this peak expiratory flow rate. During the early hours, it will be the lowest. Okay. Finally, maximum voluntary ventilation will be asking the patient to breathe in and out deeply and rapidly for 12 to 15 seconds. And now we will extrapolate to 60 seconds. Okay. We can't ask the patient to do it for the whole minute. So we'll be asking for 12 to 15 seconds. Or directly we can calculate the MVV by using FEV1. We know the FEV1, we have calculated it, right? So if we multiply it with 40, it will give the maximum voluntary ventilation. So the normal would be 160 to 180 liters per minute. If it is less than 50% of the normal value, that means they are more prone for post-op pulmonary complications. So we have calculated FEV1 and FEC. Okay. So in obstructive diseases, what happens? FEV1 is decreased. FVC is relatively less decreased. So the ratio would be decreased. Whereas in restrictive, both FEV1 and FVC decreases and the ratio would be normal. So coming to the general terminology about volumes and capacities. First, tidal volume. That is the volume of air inspired or expired during normal quiet breathing. Okay. If the patient is taking more than that, that means the maximum amount of air that can be inspired after normal tidal volume inspiration is inspiratory reserve volume. The volume expired after normal tidal volume expiration is expiratory reserve volume. See. So this is the normal tidal volume. Above that, the maximum amount the patient can inspire after this tidal volume is inspiratory reserve volume. After the tidal volume expiration, the maximum amount he can expire or exhale is expiratory reserve volume. If we combine this tidal volume with the inspiratory reserve volume, you will get inspiratory capacity. Okay. Now the patient has taken the maximum exhalation. Still, some amount of air would be remained in the lungs, that would be residual volume. Okay, please note the difference between functional residual capacity and residual volume. If it is a tidal volume expiration, then the amount remaining in the lungs would be functional residual capacity. If it is a deep expiration, that means after expiratory reserve volume being exhaled out, the amount of air still remaining would be residual volume. Okay. Coming to vital capacity, we have already seen that means after maximum inspiration, the amount of air that can be exhaled. Okay, that is vital capacity. The total lung volume is all of this. Okay. So we have discussed residual volume, capacities and functional residual capacity, which is very important for our GA also. And the total lung capacity is volume of air in the lungs after maximum inspiration. So it will include all this. Okay. Among this, you can't calculate residual volume, FRC, and total lung capacity by your spirometry. So you have to do whole body plethysmography or nitrogen washout method or helium dilution technique. So let us see that. First, helium dilution method, that will start at end expiration. So that would be our FRC, right? We are calculating FRC now. So the patient breathes in and out of a spirometer, which is having a known volume of helium, which is known concentration of helium, which is C1. And the spirometer, we know the volume of spirometer, which is V1. Now the patient inhales and exhales through the spirometer. This helium won't get diffused from lungs. So it will go inside and come out, right? So at one point there would be equilibrium attained. Now we'll calculate the amount of helium at the point of equilibrium, that will be C2. And the helium now is present in both spirometer and also in the lungs. That means V2. V2 includes the volume of spirometer and also lungs, right? So the volume of spirometer is V1 plus the volume in the lungs is your FRC because it is at end expiration. So you know the C1 value, you know the V1 value, the concentration of helium and the volume of spirometer in the initial before the equilibrium. After equilibrium, we'll again measure the concentration of helium in the spirometer. And the V2 we have to calculate. In the V2, you know V1 already. So the remaining would be a FRC. This is one method. The other method is nitrogen washout method. In this, the patient is already breathing in room air. That means in lungs, he will be having nitrogen at a concentration of 80%. So you know the initial concentration of nitrogen and the volume is FRC, which you have to calculate. Now the patient is made to inhale through a spirometer which has 100% oxygen and the exhaled air is collected. Okay, as the patient takes 100% oxygen for almost 6 to 7 minutes, all the nitrogen would be washed out and the lungs would be filled by oxygen, right? Which is nothing but denitrogenation. So, while exhaling the nitrogen, we'll collect in a bag and calculate the concentration of nitrogen after 6 to 7 minutes, which is our C2. And we'll calculate the volume of exhaled air, which is V2. This we can calculate, both C2 and V2 we can calculate. We know the C1 already, so we'll be calculating the V1, which is nothing but a FRC. Okay, so these two are the methods to calculate FRC along with whole body plethysmography. So by doing this, the complications would be atelectasis, absorption atelectasis, elimination of hypoxic drive, especially in COPD patients, it would be very much harmful. And even if we take risk, there would be underestimation of FRC due to trapped gases. Okay. The third one is diffusion capacity. So what basically we have to do, we have to send one gas inside and see the diffusion. Okay. So we'll be using carbon monoxide. Okay. The technique which we use is single breath technique. Here the patient inspires a gas which contains carbon monoxide of 0.3% and a tracer gas, for example, helium, and the rest would be the normal like oxygen 21%, nitrogen. Okay. Now, at full inspiration, the patient inspires. Now he has to hold the breath. Means he has to give some time for diffusion. So he'll be holding the breath. And now he'll exhale out. In that exhaled air, you'll calculate the amount of carbon monoxide. So that would give you your diffusion capacity. This diffusion capacity decreases in interstitial lung diseases, obstructive lung diseases, and pneumonectomy cases, while it is increased in left to right shunt and the conditions in which there is increased intrapulmonary bleeding. So, if there is decreased HP in anemic patient, there would be underestimation of DLCO, where if there is increased HP, there would be overestimation of DLCO. Okay. Now you have calculated DLCO. If it is decreased, you have to see the total lung capacity. If the total lung capacity is increased, means it is emphysema. If the total lung capacity is also decreased along the DLCO, it means parenchymal disease. Okay, so you will be calculating DLCO for that is single breath technique. The patient will inhale, he will hold his breath for at least 10 seconds and exhale, and we'll be measuring the carbon monoxide through an analyzer. Okay, so if the DLCO is decreased, now you'll be seeing the TLC. If it is also decreased, it means parenchymal disease. If the TLC is increased, but DLC is decreased, that means it is emphysema. Coming to respiratory muscle strength, we have two types, volitional and non-volitional tests. Volitional tests include body plethysmography and esophageal studies, which includes placing or inserting a esophageal catheter into the esophagus. Okay. So, firstly, body plethysmography, it measures maximal inspiratory and expiratory pressures at FRC and TLC respectively. Coming to esophageal studies, in this we'll insert a double balloon esophageal catheter and measure transdiaphragmatic pressures, maximum sniff pressures and cough gastric pressures. So, these are volitional. Coming to non-volitional, here we'll test muscle strength, we'll stimulate and test the muscle strength. For diaphragm, we will do phrenic nerve stimulation by electric or magnetic method. While for abdominal muscle stimulation, we'll go for magnetic stimulation at 8 to 10 thoracic vertebrae posteriorly. Coming to test for cardiopulmonary interaction include stair climbing test, which means the patient will climb some flights of stairs. If he can climb greater than 5, that is very good. If he can climb at least 3 flights, he is less prone for morbidity. But if he can't go for at least 2 flights of steps, that means he is a high risk patient. Okay. Coming to 6-minute walk test. That means we'll ask the patient to walk a certain distance in 6 minutes. If he can walk at least 2000 feet in 6 minutes, that means his VO2 will be greater than 15 ml per kg per minute. There is other method. We will calculate the distance walked in meters. Suppose it is x meters. And we will divide it by 30. This will give his VO2. That means if he has walked 600 meters in 6 minutes, that means his VO2 will be 20. Okay. Coming to shuttle walk test, here we'll have 2 markers which are placed at a distance of 10 meters. And the patient is asked to shuttle between these two at increased speed. Okay, he is unable to shuttle at least 25 shuttles, that is less than 25 shuttles, that means less than 25 to 50 meters, because one shuttle is 10 meters, right? His VO2 is less. Coming to VO2 measurement, it is some sophisticated technique, because we have to measure exercise ECG, we have to measure exercise changes in heart rate, and we have to measure the oxygen consumed by that person in 1 minute. So, this is a little bit difficult. So, in place of this, we are measuring by 6-minute walk test or shuttle walk test or stair climbing test. Coming to bedside pulmonary function test. It is a bit difficult to remember the names. So, this is not an actual mnemonic but a silly one. At least through that one, we can remember some of the names. So, please remember there are 2 persons, Snyder and Sabresis. Okay. So, the mnemonic is Snyder, whistled rightly, because he has whistled good, while Sabresis, the other person, is coughing forcefully. Okay. From here, first Snyder, it is Snyder's match test. Okay. Whistles. That means De Bono whistle test. Rightly. That means right spirometer. Sabreses. Sabreses has two things. See, sabreses. That means in this you have to remember breath. Sabres. Say breath. So, breath holding. Breath count. We'll measure these two, breath holding time and breath count. Next, coughing. Cough test. Forcefully. Force expiratory time. Okay, these are the names of the tests. Okay, in these tests, what we will determine first, match Snyder's match test. That means match MA. So it gives maximum breathing capacity. Okay, it gives maximum breathing capacity. Coming to De Bono whistle test. That means we are whistling here. For whistle to form, what we have to have is some expiratory flow of air. Some air has to flow in expiration. Inspiration, it's not in inspiration, right? So some air has to flow in expiration. So there is expiratory flow. That means it gives peak expiratory flow rate. So whistle is for peak expiratory flow rate. Right spirometer, we have already seen the spirometer thing. Okay. Breath holding, that means we ask the patient to hold the breath. We'll see the actual procedure, but for just at least remembering the names and what it will determine. Breath holding, that means we're asking the patient to hold the breath. That means he is holding, he is keeping something in reserve. So it calculates cardiopulmonary reserve. Breath counting, that means in exhaling, he'll be counting numbers. That means we will be counting vitals, right? Like pulse rate, we'll have some time and we'll count. We'll see the time for 6 seconds or 10 seconds. We'll count and extrapolate later, or we'll count the respiratory rate. So, counting is for vital. So, he'll get vital capacity. Cough test. If he can cough properly, that means his respiratory muscle strength is normal and his FVC is normal. And finally, forced expiratory time, we'll see how much time he is taking for expiration, so that in obstructive, it takes more time. In restrictive, the time is decreased. Okay. So we'll see them one by one. First, De Bono whistle test. It will have an outer cardboard and inner plastic tube. Through this, the person is asked to blow out the air, and we'll be increasing the leak here. Okay. At one point, the whistle will stop. So, we at that point is his peak expiratory flow rate. We have seen that whistle means it determines PFR. So first, patient blows forcibly into that mouthpiece and will increase the leak, will increasing the size of the leak till whistle is stopped, and that last size of the leak hole is called with the whistle is called PFR. Okay, is the person's PFR. Coming to Snyder's match test, we have seen match means maximum breathing capacity. Here what happens is we'll match a light, either candle or match, and we'll keep it at a distance. So the patient has to blow that off. So if he can blow off that match at 6 inches distance, that means his MBC is greater than 60 liters per minute. If he can do only at 3 inches, means it is about 40. If he can do it even at a distance of 9 inches, means his MBC is greater than 150 liter per minute. Coming to sabreses, we have two. Sabreses, we have to remember breath. It is breath holding time and single breath count. Breath holding time indicates holding means reserve, right? So it indicates cardiorespiratory reserve. So the patient has to breathe in and hold the breath. If he can hold the breath at least for 25 seconds, it means his cardiorespiratory reserve is normal. If he cannot hold, and if the breath holding time is less than 15, it means poor reserve. Coming to single breath count, that means patient inhales and exhales counting the numbers. Okay, if he can count at least 40 numbers, that means his, what it tells, counts. Counts means, breath count means vitals, right? Vital capacity. So if he can count at least 40 numbers, it means his vital capacity is normal. Coming to cough test, it indicates vital capacity and respiratory muscle strength. So, ineffective cough means there is decreased vital capacity. Okay. Coming to forced expiratory time, now the patient is asked to take deep breath and he is set to exhale the air forcefully at the maximum intensity. Now we will put a step on the trachea and we will count the expiratory time. Normally it is 3 to 5 seconds. If it is increased, that means when will it increase in obstructive? There is some obstruction for the expiratory gas to come out. So in obstructive cases that will increase, whereas in restrictive it will decrease. Okay. Next, right spirometer. We have already seen about spirometer. So it is a portable instrument and we can measure different volumes, but it underreads at low flow and overreads at higher flows. And we can also determine the tidal volume by the formula minute ventilation respiratory. Right peak flow meter. With this instrument, we can also measure peak flow of the person, and it is mainly used in asthmatics and it depends on patient effort and also the age. Microspirometers are nothing but newer models of that spirometer, and we can measure the volumes, flow, volume curves, and FEC, FEV1 and peak expiratory flow rate that we have already seen before. And there is vitallograph which gives single vital capacity breath. And finally, which we routinely do in the wards are pulse oximeter and ABG analysis. So, this is pulmonary function test and a whole. First, pulmonary function test, 6 subheadings we have seen: function test, static and dynamic 2. Now, respiratory muscle strength. Now, diffusion has to occur and cardiopulmonary testing. Last one is metabolic measurements. And among that, after that, we have seen about bedside pulmonary function test with the mnemonic. Okay. Now, how to interpret? Now, we'll see FEV1 by FEC ratio. If it is decreased, means we have already seen the ratio is decreased in obstructive. In restrictive, it is normal or slightly increased. So, normal ratio might be in restrictive and also normal lung, right? So, if it is decreased, it is obstructive. If it is normal, it is restrictive or normal lung. So, how to differentiate between these two is, we'll see FEC and TLC. If both of them are decreased, it is restrictive. In obstructive, we'll now give a bronchodilator. And now we will measure FVC and FEV1. If that gets improved with the bronchodilator therapy, it means it is bronchial asthma. If it is not improved, it means it is COPD. Now we'll go for DLC. If the DLC is less than 80%, we'll see the residual volume and functional residual capacity. If both of them are increased, it is emphysema. If the DLC is greater than 80%, but residual volume and FRC are not much affected, it means it is chronic bronchitis or asthma. Okay. In restrictive, if the TLCO is less than 80 and decrease in residual volume and FRC, it is intrapulmonary restrictive disease. If the DLCO is greater than 80% and RV and TLC are not much affected, that means it is extrapulmonary. Okay. So this is how we will differentiate between obstructive and restrictive and different obstructive diseases and intrapulmonary and extrapulmonary restrictive diseases. Okay.